the things change so fast from one day to another. I have to get the update now just before I can to make sure I give you the correct information. But when you leave here, the number of cases might have changed again. So just before we arrived here, we stood at 89,000 confirmed cases globally. 95% of them are in China. And then there's about a 3% mortality figure of those that have been infected. And also since yesterday to today, the World Health Organization, they do a risk assessment on what is the relative risk globally or regionally, etc. So we were at a high risk this morning, and it has changed now globally, all countries to very high risk. It actually is not, it doesn't make a difference to us. Our approach has always been, it is not if it's going to happen that we get a case, it is when it's going to happen. So that's been our stance, that our preparedness should link to that particular scenario. So what are the main aspects of our strategy? So the first thing is for us to early identify, isolate and care for patients should they come in our country or in our province, to be able to do that. So all our energy at the moment is to early identification and then to isolate and to care for. And then obviously to contain the patient, and then if there are any contacts, to look what are the contacts, how could we look at that, and Dr. Kluti will talk more about that. Then a critical aspect, and that is actually what we need to start doing now already, is to say that what can people do to transmit the distribution of any virus, of which the novel coronavirus is just one of those coronavirus. How do we strengthen our communities and our families to be able to care for themselves? And we will talk about that as well. Part of our prevention, our strategy, is to establish, and we've got that, and we've learned such a lot of lessons from previous disease outbreaks, from the water crisis that was in our province, and from that we've built a lot of networks with private hospitals, with the military, and in this case also the AXA, the airports company, even with embassies, with tourist companies, all of those, to build relationships and networks to say that how can we support each other, how do we make sure you have the correct information. And in the position of responsiveness, we meet on a regular, quarterly, a weekly basis. We meet with all our private hospital groups, the laboratory groups, make sure that our SAPS is in line, the airport company. All of those are the organizations that we pull in and link up to say that how do we collectively prepare for, but also be able to respond. The second aspect that we focus is to build on the previous learnings of epidemics. How do we respond? What have we learned from those responses? But more particularly so also, what relationships have we built to make sure that we can respond? We've also done a few dummy runs, what we refer to as dry runs, but also a few wet runs. So the dry runs where we make a nurse now a patient, and we say we took the patient through the journey of what would happen to test our systems. But then there were a few cases where there was a history that made us to ask, should we not test this person? And that we call as a wet run, and we've also done that and test our systems to see what works and what doesn't work, and Dr. Smith can elaborate on that. We've also established a Provincial Operations Centre, and Dr. Smith can talk about that. And then we are on a daily basis in contact with the National Infectious, the NICD, where we connect, that is the central laboratory in this country. Every possible case that are tested is known to the NICD. And they test, and they will make a declaration whether this person is positive or not. So we are connecting with all of those. So the main purpose today is to give you the reliable information, and also in the future to take notice of that. What is important is that as the World Health Organization is learning about the disease and learning about the virus, there are some changes that happen over time. That one day they might give you an indication of one aspect, tomorrow it might change. And I think that is why it's so important that having the reliable information from a reliable source is the critical thing. And in the press release that you will get, you can get where are the websites, where's the contact numbers, who can be contacted if there are any questions. I would like to hand over to Dr. Kluti who will then talk about kind of more in the kind of the patient space, the contacts, etc. Thank you.
Thank you very much, Dr. Engelberg. So I just wanted to pick up from what we, Dr. Engelberg, just had a discussion about where countries find themselves in relation to COVID-19. We find ourselves in the situation that there is no confirmed cases in the country. And that is a specific situation we find ourselves in. You obviously have followed. There are other countries that find themselves in different situations. There are countries where there are some cases and they've been able to contain them. That's another situation you can find yourself on. But then there are countries where there are cases and there's ongoing spread between people. We find ourselves in the first situation, which is there's no confirmed cases. So very much our response currently is geared towards what do we do to be able to detect if there's any cases in our country. So that is the premise from which we operate. So what we currently have, that the biggest risk for us coming into the country would be people coming into the country from areas where they would have been in direct contact with somebody that has the virus in another country, in one of those other countries that I've described to you. So therefore our efforts are very much geared to people entering our country. And that would be for Cape Town, but in South Africa, it's definitely Oliver Tambo Airport, and then for us, it's Cape Town International Airport. We also potentially have people coming via the sea, which is, via ships and all of that, but Dr. Smith will also go into that. So our biggest risk at the moment is people entering via the airports into our system. So what we currently are looking at is how would you identify somebody that comes into the country that is potentially somebody that should be investigated to see whether they have the virus or not. There's an official definition that comes from our National Institute of Communicable Diseases, the NICD, and we like to refer that as a person under investigation. So it's PIU. It's an official term we're all using now. And there's specific criteria for what qualifies you to be a person under investigation. It is whether you have specific symptoms that points to a cough or a fever or some illness, but specifically linked to that you've got a history that you've been in contact with somebody. So your travel history must be, and this is what Dr. Engelberg was talking about, that definition of a person under investigation has shifted from 4 weeks ago to now. Because now that definition includes whether you have also traveled to a country like Italy, which it was not 4 weeks ago. So that definition also gets updated because our travel history is not only China now, because people have got cases in other countries where there's free transmission of the virus between people. So having got that definition, our people in the airport are then geared to say, there's a questionnaire, have you come from that area? Have you got any symptoms? And therefore you qualify as a person to be under investigation whether you have the virus. The next step is once we've made that designation, it's about taking the appropriate samples to be assessed firstly, and the appropriate sample. So it's a throat swab, and then we send that sample off to the NICD lab. That is a registered lab, one of the only 2 registered labs in Africa for this test. And that's where we then get confirmation within 24 to 48 hours whether you have the disease or not. And we've sent quite a few samples, and all the results we've had over the last 3 or 4 weeks has all been negative. That's why we can confidently say nobody that fits that description has got a confirmed case in the country. I think the last point I just want to make is that we are gearing our entire system, because of our previous history, that wherever you go, we're gearing our health facilities. So we've brought all of this information to the attention of all our healthcare workers in the different hospitals where they find themselves. And we are gearing people to be able to communicate and talk to one another. And then us providing the updated information as the conditions and the information around the disease progresses. Thank you, Dr. Engelberg.
Thank you very much. Dr. Smith?
Thank you so much. So I want to maybe take a different point of view on this and ask any of you, what do you think patients feel like when we collect them at the airport? They're petrified. So we are working really hard to have a patient-centric approach to issues, which means communicating with our patients. Because when we arrive at the airport and we got all our PPE on, even the pilot is petrified. All right? So then as we take that further out of the aircraft, what about the population? How's the population feeling with fake news that happens, with cases that are reported the same patient, the same case, which only the names, etc., has changed? And I think the kind of setting the communication channels is very, very important so that we can get the right news out. Because the other thing that's happened, and unfortunately we're seeing it, is a stigma becomes attached to things. So anybody that's come from a certain part of the country you don't want to do anything with, you don't want to do business with, and we need to get out of that space. So I'm actually looking at, and I think where we look at strategies worldwide, what is helping with managing a lot of these type of incidents is the whole of community getting involved. Not just the medical, not just the epidemiologists, the whole of community. And that way, if you can curb the false information, or if you can assist us in getting the right information out, it can make a big difference, but most of all, a very much a patient-centric approach. So we spoke about the patient under investigation, and Dr. Engelbrecht spoke about the dry runs and the wet runs that we've had. So working very closely with partners that we've worked with for many, many years and in similar type of incidents. So the system is robust in that we've tested it in the past. It's not something brand new which we're doing for the very first time. So AXA Fire and Rescue, Port Health at the airport, right the way through to Dr. Talyard and his team at Tygerberg Hospital. And everybody working incredibly hard to identify, to be patient-centric, and to make sure that we can curtail and sort out that very first patient that may come into our system. We have been transporting quite a few patients. I think about 6 we've moved from the airport. So you can imagine as soon as they see us loading a patient, there's passengers on board, there's passengers getting out of the aircraft. If, there's the first flight, there's the first case, there's all of this. And all it is a patient that may have fitted the case definition. So I think from the department side, we'll pass that information out. And from your side is before we go in and say, there's the first case, that we can assist the public with that. So patient-centric, community-centric, I think for me is very, very important. Working with our colleagues from the private sector, private hospitals, private EMS providers, and likewise things that we do with our ports. So there was a concern at our ports that all the vessels coming in from China is going to bring the disease in. We know from the case definition that's virtually impossible. Okay, the vessels are going to take 25 days to get to Cape Town, and then they say, yes, but there can be crew changes. Well, there's a system already in place with the Maritime Risk Coordination Centre where that type of details are known to us prior to crew changes and stuff being made. Is it something we've designed specifically for this disease? No. Or for this outbreak? No. It's something we work on and do on a daily basis. So just from a patient-centric perspective, I think it's where the challenge lies for all of us as a collective, from the health professionals as well as members of the media and members of society. That people are asking the questions all the time, that the same piece of fake news has been spread all the time, means that maybe there's a concerned population out there. And it's our job to make sure we spend, as I think Dr. Engelbrecht said, the vast majority of our energy to curtail, to identify, and to make sure we can deal with that 1 or 2 patients that may arrive, to remove the stigma, and to make sure we as a collective can respond to this incident. Thank you.
Thank you, Dr. Smith. Whilst Dr. Smith was talking, I was just reflecting that not too long ago we dealt with SARS, we dealt with H1N1, we had a diphtheria outbreak, we had a measles outbreak. So clearly the system is fit to respond to these situations. But we understand that there is somehow this disease has really caught people's attention. So what we would like to, in conclusion, before we give over to questions, is that we've got a lot of other viruses also in our community. The coronavirus is a whole family of viruses. The one we're talking about is the 2019 novel coronavirus. This is what we're talking about today. But there are other viruses around as well. We've got TB around, we've got other conditions. And the basic hygiene of hand washing, cover when you sneeze or cough, and be careful to wash your hands as frequent as possible. And that habit and that behavior can actually let us rather invest in getting those things right with our families to make sure that we protect our community from various diseases. And very often people love to use social media for fake news. That goes like a veld fire. but let us rather get the proper constructive news out to say that this is what you can do. Protect your family, teach your children to do the right thing and yourselves as well. And then also please the reliable source, we give you our word. As soon as we know there's a case, you will be the first to know. I will first have to inform the minister, but then you will afterwards. We really undertake that. There's no incentive for us to hide any information. It's more important for us to get the right information out. So we really would like to leave that with you. And on the press release, at I think the very last page, there are contact details that can be used. Thank you very much.
Thank you very much, panel members. I'd like to, does everybody have a press release? Right. Okay, I'd just like to actually take you through to the last page. There is actually a link there which talks about stage a landing page created specifically for coronavirus information, where we've actually tried to upload all the relevant things there which you would need to know, and we will keep it updated. You guys know my contact details, you know Norma Wetu's contact details, Mark's contact details. We do not respond to media queries. So I would like to invite you to make use of us. We are here to try and keep you as informed about coronavirus as we are able. Okay, let's take, is there anybody with a question? I think, shall we take the first few? Okay, so we take the questions, write them down, and then ask the panel member to respond. Tamar?
Perhaps the people at the back can't hear. Perhaps you would like just to press at the bottom.
Okay.
Yeah.
From Business Day. My first question is just a point of clarity. Given how quickly this epidemic is evolving and that more than a dozen countries have confirmed cases in the past week, is it just a matter of time before South Africa confirms a case? And secondly, could you please give us a sense of your risk assessment to the health sector in terms of medicines and equipment, given the supply chain disruptions that are already evident due to the manufacturing slowdown in China? You're probably aware the FDA said last week that they had one report from one country of a medicine shortage due to coronavirus. What mitigation, what kind of risk mitigation measures are in place to protect patients?
Thank you. The lady next to Tamar.
Hi,
Just identify yourself.
Monique Mutla, NCA. With the high prevalence of TB in the Western Cape, is there, and there are thousands of people living with suppressed immune systems, is there has there been cases of people confusing TB symptoms, the prevalence of TB symptoms with the coronavirus symptoms, and how ready is the Western Cape to deal with that, where maybe possibly someone with TB or a suppressed immune system showing signs of the coronavirus? I know that it's mentioned here in the statement, the type of people or the various factors that you're looking at, people with a travel history. If you can just say that in a 4 5, please.
Okay, one more.
Good afternoon. I'm Kevin from Eyewitness News. My question is just with regard to medical aid, people on medical aid. Would I have a say in where I would want to be taken for treatment? And say, for instance, say, but I don't want to go to Tigerberg, I prefer to go to somewhere else.
Okay, I think let's do the first 3. Okay, the first question.
Okay, thanks. Thank you very much. Thanks, Tamar, for those questions. So your question is this just a matter of time? As I've indicated, our philosophy is this is not if it's going to happen, it's when it's going to happen. Obviously, nobody can predict time. At the stage, the epidemic doubled every 7 days, and it might be different now. So it's difficult to say. Our focus is on whatever it is, try to focus all our attention on the first case. And every readiness that we do is to focus on that aspect. Then you asked a question about the issue of risk assessment regarding medicine shortages. Now clearly we get medicine from various sources, and there's national tenders in place, and kind of we deal with medicine realities on a daily basis. So I think the system is quite used to dealing with areas, countries who supply us with basic stuff for medicines, active agents. Very often other countries can't provide them, they just source differently. So it has not yet come up as a particular concern. Then Monique, your question about TB prevalence and whether people are confusing this, I must say perhaps the services can respond to that. But in general, the first symptoms of should you have COVID-19 is you feel like flu, you've got temperature, you start to cough a bit. So it's kind of coldish, like a cold. And we didn't previously. I think TB and TB patients are on treatment, etc. So we do not necessarily see that correlation. I could just mention when we had H1N1, the interesting factor was it largely targeted pregnant women. The interesting was people might have thought a virus in that nature would have targeted something different. But can I ask Dr. Smith to respond and Yannick to that one?
Yes, Monique, I think that TB is a different disease. It causes slightly different symptoms. Your cough is usually productive, meaning that you cough out some stuff. Well, it looks like from the published data that we have currently on the first 2 months of the outbreak in China, that it's mostly a dry cough. So that's one thing that we can use to try and distinguish. And the other thing is also that TB is a disease that comes on over time. While this is usually something that you would become sick and you would start coughing within a couple of days after that, if not from the start. So the one's more acute onset, and the other one takes a little bit longer. But surely there can be cases where your history isn't that clear, where you might have some problems. We would think it would probably be more of a problem distinguishing between proper flu and coronavirus.
When will you respond to Kevin's question on private sector, medical aid patients?
Yeah, absolutely. I think I need to convince you. Why not Tygerberg? All right. Look, I mean, I said it's all of a community response, and Dr. Engelbrecht correctly is saying we're working hard with the private sector. So patients need to go where patients want to go, but that facility must be comfortable, must have the skill sets, etc. And that's where the planning is. It's not. It's a misconception that Tygerberg is taking everything. Okay, it's ideally from the airport to the testing, Tygerberg, but every hospital. So a lot of the queries and stuff that have come through has come from private sector hospitals, as well as some of the hospitals outside of the metro. But don't worry, we'll get you to the private facility.
So can I just say something? Because it's important, because we mustn't only focus on what is happening at a facility when we get to the patient zero, which is the patient, the first case, in terms of containment, so that the disease cannot get spread, not the disease or the virus. But remember, by the time we get the patient zero, 14 days prior that, there would have been symptoms. So we would have known to what extent the patient probably has spread the virus. Hence, it goes back to the basics, the preventive and promotive, the coughing etiquette, the washing of the hands, opening the windows, like in a taxi and all of those, because you don't know who's sitting next to you. We've got patients who also have got TB where you have to apply the same principle. We have got also other diseases where you have to apply the basic hygiene. So that's why we're saying that don't focus too much in terms of when we have the patient zero and then the containment. But there might be something that are happening outside the health system that is beyond our control. Hence the issue of the back to basics, the etiquette of hand hygiene, the coughing etiquette, and also when we have any kind of symptoms, quickly of common cold, quickly go to the next facility where they could be able to check. That is important.
One more batch. Can I give that? There was your hand up.
And the lady in front?
And the lady in front. Sorry, I think you were actually first.
Yeah.
Can I change the sequence? Okay.
You have to keep it in. Track.
From Parents 24. So we've been getting a lot of panic from parents. So what we basically need to know, the big question is, if there's an outbreak or a reported case, should they keep their kids at home? Does the department have a plan in place when that happens?
Okay, so that's the first question. Gentlemen, maybe.
My name is Sada from Hartford. Dr. Put, you mentioned that there were samples that were conducted. I just want to find out the samples that were conducted were done. They were taken from the people who were South Africans who were coming from other countries. Regarding the operations, perhaps how is it going to work? For example, if your operations are conducted at the ports or at the Cape Town International Airport, just go through what is going to be happening.
Next question.
Okay, thank you very much for that. I would think that on the issue of the parents' question, Wayne, if you could respond to that, and also the journey of the patient. And then Dr. Taljaard, I think the questions about the samples, the question about where the origin, and then also about immunity, if you can perhaps respond to those questions.
I think the very first one is the issue of education. Once the disease or the outbreak, not the disease, is of such a nature that we're worried about community transmission, then worldwide, learning from best practice worldwide, we move into something called social distancing. And that's where things like education departments would be part of the process to take a make a risk assessment and see what is going to be the best solution. And that's done, as Dr. Engelbrecht said earlier on, kind of in conjunction with everybody. And at that point in time, the Provincial Disaster Management Centre gets activated, the National Disaster Management Centre gets activated. Because we can't do one thing in the Western Cape and doing something else elsewhere. So there's a process that will go through, in particular looking at education. If the child's got flu and doesn't fit any other case definition parts of it, then why is the child not being at school? Why is it necessary to take them out? And again, I think that's the type of discussions that need to happen. And when there's doubt, the department is open to assist in those discussions, like we've done in getting documentation out to the Department of Education. So what is happening at our ports? So if I took you through the process, at the moment in Cape Town International, there's thermal scanning happening, and there's thermal scanning happening in lots of airports around the world. But we cannot just rely on thermal scanning. There are patients that can be scanned and you could have a false positive or a false negative. So the case history, asking all the passengers when they're coming through now, we've changed it recently, asking about any symptoms, asking about where have you travelled, and if there are any issues, we would move the patient aside and interrogate that a little bit more. So not just relying on thermal scanning, there's a lot of other processes that would happen. And as I said to you, through the ports of the seaports, there's a system in place that Port Health would go and make an assessment, and if they're comfortable, they would allow that vessel into port. If they're not comfortable, then there'll be a consultation with one of the physicians on call, including colleagues from the designated hospitals that can advise us on that. So as I said before, it's an existing system that we would like to utilize rather than developing something particularly for this outbreak.
Yeah, I think another point on the samples is the samples will be taken at healthcare facilities. I don't think we'll do the samples at the airport. I think we first need to do a proper assessment and also inform the laboratory and then decide on whether a sample needs to be taken. On the question of immunity, everybody is at equal risk of being infected with the virus. It is just people with a poorer immune system that can get very ill from it. Now, others get a very severe pneumonia from it. But even if you have a good immune system, you can still get infected. But it looks like people that are more healthy doesn't necessarily have the more severe manifestation of the disease, which happens in only around 5%, a little bit more than 5% of people with the disease that become very ill. And it's mostly those people with poorer immune systems. And then on the origin, yes, I think the current theory is that coronaviruses in general, the most likely origin would be from bats. There's hundreds of different coronaviruses identified in many different bats all around the world. And the SARS coronavirus was initially kind of confirmed to be from a bat originally. And this SARS coronavirus 2 that we are dealing with now is very similar to the first SARS coronavirus. So it's also presumed that it's probably also from a bat, because that's where they tend to come from.
Right. I think if you're okay with it this afternoon, we have like one, maybe two more, because I really do urge everybody to read this statement. It is very, very comprehensive, and it also points towards comprehensive information. Mark?
Can you give us a sense at the moment of the laboratory testing outside the central NHS laboratory? I was told a little while ago that provincial capacity was being built up. How far have things got with that? And are the private labs currently able to do testing? And lastly, what is your advice to somebody who has come into South Africa, who has been asymptomatic, who perhaps hasn't been checked? Do you want that, and thinks they may have coronavirus, do you want that person to go to an emergency room or a GP practice, or is there some system in place where a health authority or emergency worker can go to them to minimize the risk that they take that virus into a health facility and spread it further?
Okay, that is that question, Kevin.
At a previous press briefing, we were told that not everybody who shows symptoms for the virus will be tested, as the tests are quite expensive to carry out. If Dr. Talia can just take us through shortly, what are some of the clinical symptoms that you will be looking at in a patient if you say they're not only going to go on the raised temperature, and if we now know anything more about the virus itself? I think when we spoke to you about, say, 3-4 weeks ago, there wasn't a lot of clarity in terms of the characteristics of the virus itself. As we now tone it down a bit into giving us a bit of specifics into the microbiology of the virus.
Thank you very much, Kevin. You come from very impressed with your questions, and definitely you've learned a lot. So I agree that Dr. Talia is best positioned to answer that question, but also like Dr. Smith perhaps to respond to the NHLS and the private sector laboratory capacity, and also the advice to patients. Thank you.
Yeah, I think at the moment, and Yankee will also be able to talk about the laboratory capacity. There is definitely discussions underway to get some private laboratories accredited, and I think that's what needs to happen, is the accreditation process, because obviously we would like to, again, if you're looking at a patient-centric approach, you would prefer the patient to get the results as soon as possible and cut out any of the courier times. So yeah, those discussions are underway.
Yeah, as far as I know, I'm not directly involved with the laboratory, but there's been a big problem in the United States where they sent out test kits to different labs, and it turned out to be not good tests. So our laboratory is very careful in making sure that it's been validated. The virologist in the lab has a specific system of how they validate their testing. They need to get controls in, etc. And so that takes some time. And I'm under the impression that this process is almost finalized, and they have been in contact with different laboratories. Now we don't know which ones, to maybe then start including them. They will definitely include some private labs as well, and some public labs that's strategically placed as well, I think. On the question of going to the patients, That's definitely an option that we've also considered, but we also sit with stigma, and and you have to put on all the protective gear if you go to patients. So if we cannot be sure that people are not going to be stigmatized if we go to them to test them there, because that's something that's been also utilized in the United States to a limited degree though. Because of the problem, if you go into that house now, suddenly that house has been marked as a potential, even if it isn't the case. So I think we've been not doing it because of that fear that we have that the patient may be stigmatized. The case.
Talk about the advice to the patients.
Yeah, so I think that's a very good question about patients presenting and have got symptoms. So, if people are worried that there is a health system to go to, and the GPs, we would encourage people to do that. I often think if one looks at the numbers in China, it's probably an underestimate, because people maybe for various reasons are not going. They got slight symptoms and therefore not presenting to the health facilities. And in our type of scenario, is it this that we're dealing with, or is it something else we're dealing with? Is it H1N1 that we're dealing with? So I would encourage people, and I'm sure my colleagues as well working in the private sector would encourage, if you've got any concerns, rather present to a health practitioner who can assist you in that regard.
I just want to add to that, it's important to inform the healthcare facility or practitioner before you go, rather than to just go there and then wait in the waiting room with all other people for an hour before you get help. So I think people should understand that they should first inform wherever they want to go, and anybody should be, well, I think at this stage everybody is relatively well informed, including our primary care facilities in the Western Cape has got protocols that they follow as well, but inform them beforehand so that they can make themselves ready for you.
Through an appointment system.
No, I just want to answer the questions on the case definition as that kind of symptoms that people present with, and another one was, do we know more about the virus? So the case definition currently is you must have the symptoms, which are the kind of flu-like symptoms. Everybody doesn't have a fever always. The latest data shows that at the end, more than 80% of people will have fever, but not everybody gets a fever. So it's not necessarily the fever that is, it's a combination of symptoms, and most people have more than one symptom. And the cough and difficulty breathing is very important components of that clinical picture as well. So you must have the symptoms, and then added onto that, you have your travel history to those particular countries, or you have close contact with a case that's either a person under investigation or a confirmed case. So you've got a friend in Italy that phones you and say, listen, we were together a week ago and I've just been diagnosed with coronavirus. So you're not a person under investigation yet, but if you develop symptoms and you have that contact with that person, you would be a person under investigation and we would test you. And then also recently added is the person presenting with what we call severe acute respiratory infection, which is a person that is basically goes to the ICU immediately with severe pneumonia, and we don't know why. We would also investigate that person as a potential first case that presents in that way. Do we know more about the virus? I don't know. We know every day a little bit more, so I don't know really what to say. I think it's basically the same, what we know about the virus. We know now that it is very much similar to the SARS virus, although it's not as deadly, but it spreads easier, which we also suspected then. But the amino acid sequence is 94-95% similar to the SARS virus. So this is basically just a little bit of a different virus. That's why they call it SARS-2. So we at least know that now. And we also now know what their names are and what disease it causes. It's also good to name things. But really, the origin, the intermediate. There's a thinking process that people say that, well, bats yes, but people don't necessarily have that close contact with bats. There must be an intermediate animal. That has not been, as far as I know, confirmed at all.
Can I just add on to the question? I think there's also an opportunity to talk about the NICD hotline. So when people are concerned and they are worried that something may be problematic, there is a National Institute of Communicable Disease hotline. And that's really where we should be channeling those questions about should I be seen, rather than inundating all the emergency centres, they would then advise you, yes, go, or no, don't go, and we'll come and collect. So I think that number would be a very useful one for our community to make use of.
So thank you for that. I think it's important that we do that the public need to know what that number is. That's their first port of call. It is also important from the information that we are sharing, what is what we call a case definition of when you should be reading this number. And there are a few criteria that you can test yourself. Oh, it seems like I tick all the boxes, let me phone and find out. But if you only tick one box, you've just got a fever and nothing else, then really we should be careful how we elaborate on those. Okay.
Minister? Clear. Everybody clear. I would like to thank everybody for coming, and I would like to encourage everybody to be our partner to spread trust in the official channels, because we are all in this, and the success of our response is going to be determined how we can work together to actually take ourselves forward and to respond to the disease.
Good, thank you.
Monique?
Excuse, kan ik Afrikaans
Ja.
even krijgen? Weet niet van allemaal Trump.
Ja, kijk als.
So,